Hi everyone, welcome back to my YouTube channel. Hope you all are doing well. In today's video, I will be going over CMS final rule for fiscal year 2023, hospital inpatient prospective payment system, and long-term care hospital prospective payment system. Let's get started. On August 1st of 2022, the Centers for Medicare and Medicaid Services, or CMS, issued the fiscal year 2023 Medicare Hospital Inpatient Prospective Payment System, or IPPS, and Long-Term Care Hospital Prospective Payment System, or LTCH PPS final rule. Some of the takeaways from this rule are as follows. Background on the Inpatient Prospective Payment System and Long-Term Care Hospital Prospective Payment System. CMS pays acute care hospitals, with a few exceptions specified in the law, for inpatient stays under the IPPS. Long-term care hospitals are paid under the Long-Term Care Hospital Prospective Payment System. Under these two payment systems, CMS sets base payment rates prospectively for inpatient stays based on the patient's diagnoses and any services performed. Subject to certain adjustments, a hospital receives a single payment for the services provided based on the payment classification assigned at discharge. The classification systems are Inpatient Prospective Payment System Medicare Severity Diagnosis Related Groups, or MS-DRGs, and Long-Term Care Hospital Prospective Payment System, or PPS, Medicare Severity Long-Term Care Diagnosis Related Groups, or MS-DRGs. The law requires CMS to update payment rates for Inpatient Prospective Payment System, or IPPS, hospitals annually and to account for changes in the prices of goods and services used by these hospitals in treating Medicare patients, as well as for other factors. This is known as the hospital market basket. The Inpatient Prospective Payment System, or IPPS, pays hospitals for services provided to Medicare beneficiaries using a national base payment rate adjusted for a number of factors that affect hospitals' costs, including the patient's condition and the cost of hospital labor in the hospital's geographic area. CMS updates long-term care hospitals' payment rates annually according to a separate market basket based on long-term care hospital or LTCH specific goods and services. Changes to payment rates under IPPS, or Inpatient Prospective Payment System. The increase in operating payment rates for general acute care hospitals paid under the IPPS that successfully participate in the Hospital Inpatient Quality Reporting Program and are meaningful electronic health record users is 4.3%. This reflects the fiscal year 2023 hospital market basket update of 4.1%, reduced by a 0.3 percentage point productivity adjustment and increased by a 0.5 percentage point adjustment required by statute. This update reflects the most recent data available, including a revised outlook regarding the U.S. economy, and as a result is 1.1 percentage point higher than the proposed update for fiscal year 2023. Hospitals may be subject to other payment adjustments under the Inpatient Prospective Payment System, or IPPS, including payment reductions for excess readmissions under the Hospital Readmission Reduction Program, payment reduction of 1% for the worst performing quartile under the Hospital Acquired Condition Reduction Program, upward and downward adjustments under the Hospital Value-Based Purchasing Program. The increase in operating and capital Inpatient Prospective Payment System payment rates, partially offset by decreases in outlier payments for extraordinarily costly cases, will generally increase hospital payments in fiscal year 2023 by $2.6 billion. In addition, CMS projects Medicare Disproportionate Share Hospital, or DSH, payments and Medicare Uncompensated care payments combined will decrease in fiscal year 2023 by approximately $0.3 billion. CMS also estimates that additional payments for inpatient cases involving new medical technologies will decrease by $0.75 billion in fiscal year 2023. Under current law, additional payments for Medicare-dependent hospitals and the temporary change in payments for low-volume hospitals are set to expire in fiscal year 2023. In the past, these payments have been extended by legislation, but if they were to expire, CMS estimates that payments to these hospitals would decrease by $0.6 billion. Implications of using fiscal year 2021 data for new technology add-on payment or NTAP. Since inpatient prospective payment system payments are generally based on the most recently available Medicare claims and cost report data, which tends to have a lag of 2 to 3 years, the statute provides temporary additional payments for certain cases with high costs under the new technology add-on payment or NTAP policy. Under this policy for eligible technologies, Medicare pays the applicable MS-DRG payment rate and up to an additional 65%, 75% for certain antimicrobials of the cost of the approved new technology. The new technology add-on payment is not budget neutral and is generally limited to the 2 to 3 year period following the date the product begins to become available. For fiscal year 2023, CMS is returning to their historical practice of using the latest available data, example fiscal year 2020 MedPAR claims, to recalibrate the fiscal year 2023 MS-DRG relative weights. CMS believes the cost of technology for which the 3-year anniversary date of the product's entry into the U.S. market occurs prior to the latter half of the upcoming fiscal year and therefore are no longer new, may now be fully reflected in the MedPAR claims data used to recalibrate the MS-DRG relative weights for fiscal year 2023. As a result, CMS is discontinuing new technology add-on payments for these technologies in fiscal year 2023, and CMS is also discontinuing new technology add-on payments for the technologies that received a 1-year extension in fiscal year 2022. Applications for new technology add-on payment or NTAP approved for fiscal year 2023. In this final rule, CMS approved 8 technologies that applied for new technology add-on payments for fiscal year 2023. This includes 3 technologies submitted under the traditional new technology add-on payment pathway and 5 technologies submitted under the alternative pathway for new medical devices that are part of the FDA Breakthrough Devices Program. CMS also conditionally approved 1 technology under the alternative pathway for products that received FDA Qualified Infectious Disease Product or QIDP designation that otherwise meets the alternative pathway criteria but has not yet received FDA approval. Additionally, CMS is finalizing the new technology add-on payment or NTAP for 1 technology that it determined to be substantially similar to an existing technology approved for new technology add-on payment or NTAP in fiscal year 2022. CMS is also continuing new technology add-on payments for 15 technologies currently receiving the add-on payment that will remain within their newness period for fiscal year 2023. As discussed above, CMS is not using its exceptions and adjustments authority under Section 1886D5I of the Social Security Act to provide for a 1-year extension of new technology add-on payments for the remaining technologies no longer within their newness period in fiscal year 2023 in light of its return to using the latest available data, example fiscal year 2020 MedPAR claims, to recalibrate the fiscal year 2023 MS-DRG relative weights. In total, 25 technologies are eligible to receive add-on payments for fiscal year 2023. CMS estimates that fiscal year 2023 Medicare spending on new technology add-on payments will be approximately $784 million. Changes to new technology add-on payment policies for fiscal year 2023. CMS is finalizing its proposal with some modifications to publicly post completed new technology add-on payment applications, certain related materials, and additional application information submitted subsequent to the initial application, except for certain types of information as described in the final rule, At the time the proposed rule is issued in order to increase transparency, minimize the risk of omission or misinterpretation of an applicant's data, and increase operational efficiencies. This policy is effective beginning with the application cycle for fiscal year 2024. CMS is not finalizing its proposal to use only national drug codes or NDCs to identify claims involving the administration of therapeutic agents approved for new technology add-on payment rather than ICD-10 PCS codes after consideration of the concerns raised in public comments. CMS will continue to engage with stakeholders regarding this issue and reassess for future rulemaking. Changes related to MS-DRGs. CMS did not propose any new MS-DRGs for fiscal year 2023, which means the number of MS-DRGs is maintained at 767 for fiscal year 2023. CMS finalized the reclassification of laser interstitial thermal therapy or LTCH procedures under the MS-DRGs in connection with the creation of new procedure codes to describe LITT. CMS is finalizing their proposal to further delay implementation of the three-way split criteria because of the magnitude of the impact during the ongoing public health emergency. CMS is continuing their review of diagnosis codes along with a comprehensive review of the procedure code list, including when a procedure should affect MS-DRG assignment. A number of technical refinements to MS-DRG assignments are included. Social determinants of health comment solicitation. CMS solicited public comments on how the reporting of social determinants of health or SDOH diagnosis codes may improve their ability to recognize severity of illness, complexity of service, and/or utilization of resources under the MS-DRGs. CMS received feedback on how they might otherwise foster the documentation and reporting of the diagnosis codes describing social and economic circumstances to more accurately reflect each healthcare encounter and improve the reliability and validity of the coded data, including in support of efforts to advance health equity. Many commenters stated that they agree that codes describing homelessness have been underreported and that increasing the severity level of the codes that describe homelessness from a non-complication or comorbidity or non-CC to a complication or comorbidity or CC could prompt more rigorous documentation and reporting, and commenters stated that they believe that homelessness involves a level of care in line with diagnoses currently designated as CCs. CMS will take these comments into consideration for future rulemaking. Graduate Medical Education or GME changes. CMS is finalizing two proposed changes to their GME policies. First, CMS is finalizing a modified policy to be applied prospectively for all teaching hospitals as well as retrospectively for certain providers and cost years. The modified policy addresses situations for applying the FTE cap when a hospital's weighted FTE count is greater than its FTE cap, but would not reduce the weighting factor of residents that are beyond their initial residency period to an amount less than 0.5. Specifically, effective for cost reporting periods beginning on or after October 1st, 2022, if the hospital's unweighted number of FTE residents exceeds the FTE cap and the number of weighted FTE residents also exceeds that FTE cap, the respective primary care and obstetrics and gynecology weighted FTE counts and other weighted FTE counts are adjusted to make the total weighted FTE count equal the FTE cap. If the number of weighted FTE residents does not exceed that FTE cap, then the allowable weighted FTE count for direct GME payment is the actual weighted FTE count. Second, the law requires caps on the number of FTE residents that each teaching hospital may include in its indirect medical education or IME adjustment and direct GME payment formulas. To provide flexibility to teaching hospitals that cross-train residents, CMS allows teaching hospitals to enter into Medicare GME affiliation agreements to share and redistribute those cap slots to accommodate the actual rotations of their residents. The law also includes a provision allowing additional cap slots for urban hospitals that establish rural training tracks with rural hospitals, now called Rural Training Programs or RTPs. CMS's current regulations do not allow GME affiliation agreements for RTPs. Stakeholders have requested that RTPs be afforded the same flexibility as other teaching hospitals to share their RTP cap slots via special RTP affiliation agreements. With this final rule, CMS is allowing an urban and a rural hospital participating in the same RTP to enter into an RTP Medicare GME affiliation agreement effective for the academic year beginning July 1st, 2023. They should promote workforce development and training in rural areas where there are known challenges with access to care. Uncompensated care payments. CMS distributes a prospectively determined amount of uncompensated care payments to Medicare DSHs or disproportionate share hospitals based on their relative share of uncompensated care nationally. As required under law, this amount is equal to an estimate of 75% of what otherwise would have been paid as Medicare DSH or disproportionate share hospital payments adjusted for the change in the rate of uninsured individuals. In this final rule, CMS will distribute roughly $6.8 billion in uncompensated care payments for fiscal year 2023, a decrease of approximately $318 million from fiscal year 2022. This total uncompensated care payment amount reflects CMS Office of the Actuary's projections that incorporate the estimated impact of the COVID-19 pandemic. In response to concerns expressed by commenters that the use of only 1 year of data would lead to significant variations in year-to-year uncompensated care payments for fiscal year 2023, CMS is using the two most recent years of audited data on uncompensated care costs from worksheet S10 of hospitals' fiscal year 2018 and fiscal year 2019 cost reports to distribute these funds. In addition, as CMS expects that fiscal year 2024 will be the first year that 3 years of audited data will be available at the time of rulemaking, for fiscal year 2024 and subsequent fiscal years, CMS will use a 3-year average of the uncompensated care data from the 3 most recent fiscal years for which audited data are available. For example, for fiscal year 2024, CMS expects to use audited data on uncompensated care costs from fiscal year 2018, fiscal year 2019, and fiscal year 2020 cost reports to determine eligible hospitals' uncompensated care payments. Beginning in fiscal year 2023, CMS is discontinuing the use of low-income insured days as a proxy for uncompensated care in determining the amount of uncompensated care payments for IHS and tribal hospitals and hospitals located in Puerto Rico. Because CMS recognizes that this policy could result in a significant financial disruption for these hospitals, CMS is also establishing a new supplemental payment for IHS/tribal hospitals and hospitals located in Puerto Rico beginning in fiscal year 2023. Establishment of a birthing-friendly hospital designation. Reducing maternal morbidity and mortality is a priority of the Biden-Harris administration. To build on the White House blueprint for addressing the maternal health crisis, CMS will establish a birthing-friendly hospital designation, a publicly reported, public-facing hospital designation on the quality and safety of maternity care. CMS is establishing this hospital designation in fall 2023. This proposal was made in conjunction with Vice President Harris's nationwide call to action to reduce maternal mortality and morbidity, which included CMS's intention to establish this proposed hospital designation. As finalized, CMS will award this designation to hospitals that report yes to both questions in the maternal morbidity structural measure, reporting that the hospital participated in a national or statewide quality collaborative and implemented all recommended interventions. CMS also solicited and received comment on potential names for the designation and additional potential data sources for CMS to consider in the future for purposes of awarding this designation. CMS also issued an RFI in which CMS sought and received comments on how they can address the U.S. maternal health crisis through policies and programs, including but not limited to the conditions of participation and through measures in their quality reporting programs. A summary of these comments is provided in the final rule and will be used to inform potential future policy development. Changes to payment rates under long-term care hospital PPS or prospective payment system. For fiscal year 2023, CMS expects long-term care hospital PPS payments to increase by approximately $71 million. Long-term care hospital PPS payments for fiscal year 2023 for discharges paid the long-term care hospital standard payment rate are expected to increase by approximately 2.3% due primarily to the annual standard federal rate update, that is, the productivity adjusted market basket increase for fiscal year 2023 of 3.8% and a projected decrease in high cost outlier payments. Extensions of the Rural Community Hospital and Frontier Community Health Integration Project or FCHIP demonstrations. Section 128 and 129 of the Consolidated Appropriations Act of 2021 respectively authorize a 5-year extension for both the Rural Community Hospital demonstration and FCHIP demonstration. CMS is implementing these extensions in the fiscal year 2023 Inpatient Prospective Payment System / Long-Term Care Hospital PPS Final Rule. Revision to conditions of participation for hospitals and critical access hospitals to report data elements for COVID-19 and seasonal influenza. CMS is revising the hospital and critical access hospital infection prevention and control condition of participation requirements that require hospitals and critical access hospitals after the conclusion of the current COVID-19 public health emergency to continue reporting on a reduced number of COVID-19 data elements. The revisions will apply upon conclusion of the COVID-19 public health emergency and continue until April 30, 2024 unless the Secretary establishes an earlier ending date. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.